In this lecture, we will discuss ectopic atrial tachycardia and how it would appear on the EKG. Primary atrial arrhythmias are a form of narrow complex tachycardias. Just as the name implies, ectopic atrial tachycardia originates from a focus within the atria, but outside the sinus node. Some focus within the atria fires more quickly than the underlying sinus rate. You may also hear it referred to as an automatic atrial tachycardia. Oftentimes, these episodes are not sustained for extended periods of time. Now, we will soon see that because this rhythm is originating outside the sinus node, the P waves and the PR intervals will oftentimes be different from normal sinus rhythm. And because of the accelerated rate, we may sometimes see transient ST and T wave abnormalities. Okay, so what can we see on the EKG? Well, one of the most helpful clues is the presence of rate variability with a warm up and cool down period. This means that the heart rate will rise and fall gradually as the automatic focus increases and decreases its automatic rate of electrical discharge. This is different from reentrant form of tachycardia, in which it begins and ends abruptly as cardiac conduction uses and then stops using the accessory pathway. Okay, so this is one thing that you cannot always see on a standard 12-lead EKG, but if you get the rhythm strip, one of the main things that differentiates this from a reentrant form is this rate variability with this warm-up initiation and the cool down termination period. Okay, so you can't always see that, but that's one thing that can distinguish it. Now, because the beat is not originating from the sinus node, the P wave morphology and the axis may be different. For instance, we may see an inverted P waves in the inferior leads 2, 3, and AVF. Okay, so again, look here. Here's our green focus. Okay, in the atria and coming outside our sinus node. This is our sinus node, so it's originating from this green focus here. Okay, and it's only one of them that's starting it. And what we have is, because it's not coming from the sinus node, remember our normal P wave axis is between 0 and positive 75 degrees as the arrow heads in that direction towards this way. But now instead we have this green focus here that's going in a different direction. Okay, and because of that, we're going to have different P wave axis. Okay, so our inferior leads are 2, 3, and AVF. Okay, and normally, right, our P waves will be heading towards at least 2, so we'll see upright P waves. But in this case, if our axis is now heading in the opposite direction in terms of this way, okay, say it originates in this place and it's going retrogradely, in such cases we can see inverted P waves, so negative P waves in these inferior leads as it heads away, and we may actually see an upright P wave in lead AVR. Okay, so that's one thing to note, is that we'll have a different P wave axis. We also mentioned that the morphology will be different. Okay, so notice we have a P wave here. Here's another P wave. Okay, and then we have different P waves coming about. All right, and this blue area is where the actual ectopic atrial tachycardia that we're discussing is here. So notice our P waves are now different in morphology. Notice we have the same morphology within this this area of tachycardia, but they're different from our other sinus P waves. Okay, so that's one thing to note: different P wave axis, different P wave morphology. Okay, so those are a few main things with the P waves. Now, we usually want to see at least 3 identical ectopic P waves. Okay, because variation in P wave morphology with each beat may indicate another rhythm, such as multifocal atrial tachycardia. And that's one that we'll talk about in future lectures. Okay, in other words, the initiating P wave that we see here should be identical to the P waves that follow. Okay, and this is one of the main things that you have, is at least 3 P waves that are identical. Okay, because it's all coming from that ectopic region right here. Okay, so it's coming from the same area, so our P waves should all be the same. So our initiating P wave is the same as those that follow in that area. Okay, so you want at least 3 of them. Now we get to the AV nodal conduction, which makes up most of the PR interval. The PR interval is often different from sinus rhythm, and this is because it depends on the distance from the ectopic focus, this here in green, okay, to our AV node, this area here. This is our AV node. All right, the shorter the distance to that area, the shorter the PR interval will be, and the greater the distance, the greater that PR interval. Okay, so if we just erase this now, notice we have our ectopic focus in our AV node. this distance from here may be shorter than our sinus node to that area, and because of that we may see a shorter PR interval. However, at times it may be longer. What if it's originating from this area here, and all that area has to travel to get to the AV node, so we can see a longer PR interval. At times it may be even shorter. What if it originates low in the atria at this point? Okay, so that can give us a short PR interval. So it's that distance from the AV node and the ectopic focus. Okay, and now just so you're aware, when we talk about ectopic focus, it means a focus, some area in the atria outside of the normal sinus node. Okay, now typically we'll have 1-to-1 AV nodal conduction, meaning that we'll have one P wave for every QRS complex. That is, every depolarization wave that reaches the AV node should be conducted through the ventricles. Okay, so every impulse that comes from this thing and gets to our AV node should be conducted down there, okay, to the ventricles. So just a few more points. In terms of intraventricular conduction, the QRS complex is typically normal unless there's some pre-existing conduction delay, accessory pathway, or rate-related aberrant conduction. Okay, we said before that transient ST and T wave abnormalities may be present due to that rapid atrial rate, or this rapid form of tachycardia. Now for bonus points, let's look at how the P wave morphology can help us localize the origin of the ectopic focus. Okay, here we want to look at lead V1. This lead gives us an excellent idea of the electrical conduction in both atria. It's a short axis view. A negative or biphasic positive-negative P wave in lead V1 has been shown to be specific for a right atrial focus, meaning one that's originating from the right atria, so like the one we have here. While a positive isoelectric or biphasic negative positive P wave in V1 has been found to be specific for a left atrial focus, so one coming from somewhere in the left atrium. So let's just look at this quickly. Again, this is a little more advanced stuff, but I think you can handle it. Okay, so what I'm saying here is that we're looking at this area here, P wave in V1, to identify the origin. Is it coming from the right atria or the left atrium? Okay, and in this case, if we look at the right atrial focus, so again, V1 is the most anterior lead with V2 sitting over that right ventricle. Okay, the right side of the heart is more anterior to these leads, okay, these right precordial leads that are sitting over the right ventricle, okay, right on the chest. And what we're saying here is if we look at a right atrial focus, so one in the right atrium, like this green one here, what we're saying is that we'll either see a negative wave, okay, meaning that it's moving away from these leads, as you can see here. So we'll see a negative P wave, or we can see a biphasic P wave, but if we see a biphasic P wave, it's going to be positive and then negative, okay? So why is that, okay? So in this case, you got to remember that the right atrium sits the most anterior way. So if you imagine a focus originating here, imagine it going this way, okay, or more anteriorly, or rising here. So it's depolarizing this right atrium first, so we'll get that upright P wave, just like we see in the sinus rhythm, okay, and then it'll depolarize the left atrium and head backwards, okay, and that negative portion is depolarizing the posterior part of the atria, the left atrium, okay. So again, that's the right atrial focus, all right. Think of it very similar to a sinus P wave. Now the other thing we can see is if it originates in the left atrium, okay? So if it's originating in the left atrium, it could be positive, meaning that it'd be like this, or it would be isoelectric, just flat, okay? Or it could be biphasic, okay? And in this case, if it was biphasic, we said it could be negative and then positive, okay? And this is an abnormal P wave. We usually don't want it going like that, but it should make sense why that's the case, okay? Again, imagine one originating here in the left atrium, okay, again going backwards to depolarize the left atrium where it's originating from, so we'll get that negative deflection going down, and then it'll come forward and depolarize the right atrium, and because of that, as it heads towards that lead V1, it will see an upright deflection, okay, so hopefully that makes sense, okay. So what else do we have going on here? So that was a little extra, but I knew you could handle it. And let's just review our chart so we don't miss anything. Okay, so we'll go through our chart here. So again, the ectopic or automatic atrial tachycardia, remember the pacemaker within the atria fires at a faster rate, okay? And we said that green area here in our right atrium is firing faster than our sinus node, and that's why we're having this takeover, okay? Remember, the general rule is that the fastest pacemaker controls the heart. So this green ectopic focus is firing faster than our sinus node. In that case, it takes over. And this often, the mechanism involved is an increase in automaticity. Okay, so that's one thing you can know. Now, one of the differentiating factors we said from a reentrant form was this rate variability. We have this warm-up initiation, so the rate slowly warms up and gets faster, and then this cool down termination, meaning the rate slows down, okay, and settles. You can't really see that here, and oftentimes you need a longer rhythm strip to see it. Now, one other thing to note is we can see transient ST and T wave abnormalities, so in this region here, but in that tachycardic area, okay, and that's because of this rapid rate. That's why we'll see that. Now, in terms of regularity, it should make sense that we're getting a rhythm that's originating from the same area, okay? And because of that, all these intervals here from one R wave to the next are all going to be the same. So because of that, we call it a regular rhythm. It's tachycardic, all right, above 100 beats per minute, just as the name implies. Atrial, so atrial rhythm that's fast, okay, as we see here. And the range could be between 100 and 250 beats per minute. Now, we said the P wave morphology will be different from the normal sinus P waves. We said it could be inverted in those inferior leads. Think about it. Here's our leads. Here's lead 2. Here's lead 3 and lead AVF. Okay, and think about it moving away from those leads, or even around here, moving away from those inferior leads. And because of that, we can sometimes see these inverted P waves in those leads. We want to see at least 3 identical ectopic P waves, okay, as we saw here. At least 3 of the same to call this an ectopic atrial tachycardia, okay? If there were different P waves, we'll get into something else called multifocal atrial tachycardia. Now, we talked about the P waves in V1, how they can identify the origin, okay? With the right atrial focus will be negative or biphasic, positive, negative, okay? Or if the left atrial focus will be positive in V1, isoelectric in V1, or if it's biphasic in V1, it'll be negative and positive, okay? There's that one-to-one relationship between the QRS and the P waves. Remember, even though we're originating here, it's getting to our AV node. We're still getting a P wave because the atria are depolarizing, and it's getting down to the ventricles. So we have that one-to-one AV nodal conduction. The PR interval is often different from the ectopic focus. Remember, it depended on where in the atria originated. If it'd be shorter or longer from that AV node, we'll see a longer PR interval. The width is normal, okay? So notice our width here is normal throughout because conduction into the ventricles is pretty much the same. Once we get down here in this region, everything is happening the same. It's only up in the atria that things are different, okay? Unless there's some pre-existing thing, IVCD is an intraventricular conduction delay, accessory pathway can cause this, or rate-related aberrant conduction. Sometimes you can see that with these faster rates. Now, in terms of grouping, there's no grouping and there are no dropped beats, okay? So that's the end of this lecture. We discussed ectopic or automatic atrial tachycardia and how it may appear on the EKG. I hope you learned something.